going to start welcoming people to the program today. We'll drag our feet a little bit because we have a lot of people joining. I think we have about 580 signed up in advance, so we'll give them a chance. I hope some of you were here for the dialogue that George Rutherford and I had a while ago in the era of COVID. It's any time ago is like an eternity. Things change so fast, but welcome back if you were here before. If not, welcome to this program. This is a program of the International Antiviral Society USA, and we are happy to be today talking with George Rutherford. George Rutherford is a professor of epidemiology and biostatistics at the University of California, San Francisco. George is a pediatric ID person. So for those of us that come to this dialogue with an interest in HIV and in infectious disease, he brings that perspective to this work, and has been very active, just amazingly active in responding to the COVID epidemic here in San Francisco, really helping establish case contact tracing, helping train and staff thousands of people that are doing that work. So he really knows what he's talking about. We will have about 40 minutes for a conversation that I'll moderate with George. During that time, you can put in questions as they come to you in the Q&A function on the Zoom screen. Our staff will be looking at those, and when it comes time, at the last 20 minutes or so of the program, they'll toss me those, and I'll then again ask the questions to George to respond. This is not a CME program, but it is available, and just kind of fair warning, as you all know, I think the information about COVID changes so fast that while it will be posted, I think it's likely that we'll come back to this and at some other time. I'm not sure how many times we can get George to join us, but as long as he keeps saying yes, we'll keep asking him back. We might have some polling questions during the program, but I don't think we have any planned right now. But we have that capability, and if we do that, we'll kind of give you some warning. So, George, welcome back.
Thanks, Paul.
Yep. Yeah. So, just talk a little bit about yourself and what it feels like to have been trained as an infectious disease epidemiologist and then find yourself tossed into this.
I feel somewhat prepared.
Yeah,
I have to say, given as opposed to a lot of other people. So I did peds and was a fourth-year chief resident running ICUs. So perfect preparation. You know, learning how to put Swan-Ganz catheters into 3-kilogram babies. Perfect preparation for this. Then I went to CDC, and by that I mean the Centers for Disease Control, and not the California Department of Corrections, lest we'll talk about correctional health here in a second. It's just like There's no confusion there. I was an EIS officer, an Epidemic Intelligence Service officer, and was in Atlanta, New York, and got in on the very early days of the AIDS epidemic. I was transferred by CDC to San Francisco in 1985, where I met Paul and Don Abrams and Connie Wofsy. And so I've been on that epidemic for pretty much for most of my career. But I also sort of stepped out of AIDS for about 5 years and was a chief of infectious disease for the state of California and the state health officer. There's a pretty broad view of public health from that. And, and I also worked on Ebola and tuberculosis and chlamydia and coccidioidomycosis and a variety of other diseases, the 2009 swine flu. But this is obviously I mean, I don't know what to say when people say, "Oh, this is the biggest epidemic we've had." I think HIV is a bigger epidemic, frankly, in terms of mortality, and I have to keep reminding people
Right,
of that.
right.
But it's just has a qualitatively different feel to it,
Yep, yep,
as you
yep.
know, Paul.
As we all know, right, right.
You don't get it walking down the street or at the
So,
market. Yeah.
so I mean, we can start anywhere, but I'm curious about your thoughts just about where we stand in the epidemic. We hear of these hot spots at the first part of the epidemic in this country, New York and New Jersey. Um,
Yeah.
Now they seem to be
Yeah.
very quiet, and then we've had that raging inferno in the South and Southwest. Just what's your thought about how things stand? Are we entering the fall lull season, or speculate?
You wish.
I wish.
Yeah, you wish. We've gone through we're starting down the downslope of the second wave of the epidemic. These aren't, true waves in the sense that it returned to baseline, but you can really see a second wave that was involved the whole of the South and Southeastern United States, with the various hotspots moving around from Atlanta to Miami, back to New Orleans, to Houston, to Brownsville, and every place in between. And they've just been, pounded by that. I think Houston probably did get up to the levels of New York City for a while in terms of having to triage and ICU availability, and just sort of totally brutal kind of impact on the medical
Right.
care system. Here in the West, it's a very different story. It's been even though we're really in a second wave now too, and we may have turned the corner. A little hard considering that 300,000 cases got lost out of the state registration system a couple of weeks ago. But I think we're beyond that, and we can say that we've turned the corner as a state for California. I'm less clear on what's happening in Oregon and Washington now, but in the Bay Area, maybe not turned the corner. But that's a disease. It's become a disease that's very much a predominantly an infection in the Latinx community. And what we've seen is it move out from the cities and basically highly densely populated parts of the city. So in San Francisco, in the Mission District, and Los Angeles and East Los Angeles, where there are a lot of people living, multi-generational families in single houses or even in apartments. It's moved from there. It's moving into the agricultural lands, and you can see it really extends all the way from the Imperial Valley through northern Washington, all through the choice agricultural areas going up. And that's because we have a largely Latino workforce that's there working in the fields. And I've tried to get data from British Columbia to see whether it extends into there. They don't categorize people like we do. They're interested in First Nations, and that's about it. But I wouldn't be surprised at all. But it's really a Latino disease now in the West, with all sorts of additional unhelpful things, from fraternity parties and bars and clubs that stay open too late, and big parties in Los Angeles, and all that stuff that just adds cases on top of it. But the base is predominantly Latino.
And the explanation for New York and why it is so quiet there, any thoughts?
Well, I mean, everybody's scared. There people wear masks. At least that's my impression. That people are really are much more conscious of it than they are in other parts of the country, and are really taking precautions and are really treading lightly. There is something that came out this week about is there a herd immunity? Is there modeled herd immunity in parts of Brooklyn and Manhattan and the Bronx? I find it pretty hard to believe that you can get to herd immunity at 50%. That would mean the R naught would have to be 2, and we know it's somewhere around 3.5, or maybe even up to 4 in certain places. The herd immunity is the R naught minus 1 divided by R naught. So
right.
If you had 2 minus 1 divided by 2, that would be a half. Plus, we have all sorts of other things that would say that that's absurd to think that it's that low. San Quentin State Prison here is topping out at around 70%. Some ships have topped out at 90%. Now, those aren't, that's not single family dwellings in suburbia, obviously. But it would suggest that you need a lot more infection to get to herd immunity. And there are some slums in Mumbai, again, not single family dwellings in the suburbs, that are topping out at around 60%. So I think you're probably looking at 60 to 70% for herd immunity, just based on what we've seen. And that stuff's so behavioral too, because it's about exposure and who's going to put themselves at risk. It's really going to be different in different places. But as to whether that, as to why that's, as to if that's a reason that things have gone down in New York, maybe a little bit in some places, but I really don't think so. I think it's really behavioral. Yeah.
And I would assume that the whole topic of herd immunity relates to questions of post-recovery immunity, which relates potentially to vaccine status. Do you want to talk about, I know it's a big topic, but the evidence that somebody who has recovered is or is not safe from this?
Best article of the week, of course, in Med Archive. And it's from Seattle. 122 people were crewmen on a U.S. fishing vessel. Pre-departure, there were 120 that were screened, and nobody was infected. They were screened for antibody as well. 3 people had neutralizing antibody. They went to sea. They had an attack rate of 90%, and the 3 people who had pre-existing neutralizing antibody got 0 disease, did not develop, were not NP positive, NP swab positive, and had no symptoms at all. I think that, there's a real kind of clear example of neutralizing antibody being protective. Now, they would have had to have gotten it in the last first case in Washington State was in late January. They would have had to have gotten it in the last 6.5 months, but still, I think that's pretty compelling evidence. The other thing is there's a large study that came from Shanghai that titered people's neutralizing antibody titers, and they said that and I'm not going to get the numbers right, but about say 13%, 14%, something like that, had high titers, and they had it stratified into 4 levels. And something like 25% had very low or completely absent titer. So, it's the fact that you get it. It sort of depends on what happens with your immune response. Or a lot of people, there's at least 10 out of this cohort in China, and I can't remember the N here, but it's 100 and something that had no antibody response at all. So that's, I think, a sobering thought before we let everybody go out and get infected.
And we've heard some discussion recently about comparisons of antibody part of the immune system versus cellular immunity. HIV docs often think about cellular immunity. We don't do any testing for that, though, do we?
Yeah, you can do. It's complicated. You can do it. It's for research purposes. There is an emerging literature on cellular immunity. I don't know it very well, Paul.
Yeah.
But it would not surprise me if there was some degree of cellular immunity with this. But I still don't. I think that's a big stretch to say, well, everybody in New York has cellular immunity because they got infected, and therefore they're all immune, and therefore they don't have to worry about anything. I think that's a major stretch to go that far.
Anything, I wanted to talk about a couple topics that I'm sure people are going to be interested in. Schools opening. I want to talk about the flu season and what we're going to do. But maybe just talk a little bit, give us an update about testing and where we stand. We've heard about very rapid tests. We've heard of tests that are so rapid that people are hiring testers to come to their parties and test people when they come in. Craziness.
People don't have enough to do, right?
Right.
Testing's all over the map. I think we're starting to recover our capacity, and there are a number of test systems that are available to do molecular tests to do antigen detection and to do antibody tests. So first of all, I take for, unless you're somebody like me who wants to do seroepidemiology, I just take antibody tests and set them aside, right? We may at one point in time, if it turns out that there's some kind of antibody dependent antibody enhancement with the vaccine, we may want to screen, like we get with dengue, for instance.
Right.
We may want to screen for antibodies prior to vaccination, but that's science fiction right now, so I wouldn't worry about that. So the two tests are antigen and molecular tests. The molecular tests we're now down to having the FDA give approval, emergency use authorization for salivary tests, and I'm not talking oral swabs. I'm talking about spitting into a cup.
Yeah.
And we're also either oral swabs, they're nasal swabs, they're self-administered nasal swabs, they're dry nasal swabs, they're the old NP swabs, which are extremely unpleasant. But it's all most of that stuff's gonna hinge back to PCR technology. Antigen technology is there, and we can measure antigen as well, which comes up kind of with the RNA that's shed when you're PCR positive. But it's not very sensitive. It's on the order of about 50% sensitivity. But the important thing is, but wait, the important thing is that I think we're really getting a much better feel for what the real infectious period is and how infectious you are when people are getting infected. And this is from super spreader.
And that it might be quite short, right?
Yeah, like 3 days.
Yeah.
So we know that you can turn PCR positive 2 days before symptom. So let's just talk about symptoms, right? Yeah. And forget asymptomatic infection for a bit. But if you do develop symptoms, you start to shed RNA a couple of days, 48 hours before symptom onset, and then we'll shed it for some long period of time afterwards. We've done this. The studies have been done to look at recovery of viable virus as a function of duration from symptom onset, and that period's about 8 days, but it drops off pretty rapidly. And what appears to be happening is that you have peak viremia, not viremia, but peak viral shedding on days 4, 5, and 6, maybe 7. That it's a really tight period of time, and people have a lot of virus when that's going on. We're talking like 10 to the 7th particles. And so as we rethink this, one of the things that a guy at Harvard, Michael Menas, talks about is that it doesn't matter how good the test is, right? We can tolerate poor sensitivity as long as we do it frequently enough, because what you're trying to do is not catch the this distal trickling little bit of RNA that's being shed, but you want people who are really acutely infectious. And it doesn't matter how bad the test is, they're gonna pick that up. Those are cycle times of like 15, 16, 17, as opposed to this trailing thing, which are all our laboratory standards are geared for, which is like 39 or 40 cycle times. Right. So we want like big disease, right at that point in time, because that's where you're going to get the most bang for your buck from isolating people.
Right.
So there's kind of the testing stuff is paradigms twisting a little bit from having highly sensitive, highly specific tests to having tests that you can get easily or cheap to run, but that you can do with some frequency. So I can't remember if it's baseball or basketball. One of them does them daily, and the other does every other day. But that's the kind of thinking that they have, not for antigen tests, but for molecular tests, using things like LAMP as an example. So that's the kind of paradigm we're stepping into, which is frequent, which is trying to get as frequent testing as possible. And what we're trying to get, what's the ideal test? It's like a pregnancy test, right? Home pregnancy test. It's sensitive enough, right? It's cheap, and you can do a point of care, and in fact, you can do it yourself.
Yeah.
Right? That's the ideal here. And what we're hearing now is you can sacrifice sensitivity, because you're really only interested in the period of time when people have
lots of virus. Yeah.
Yeah.
Well, take that I know you've thought a lot about schools. So take that discussion in terms of, I mean, I know there's a lot to say in terms of how infectious are kids at what ages and all of that, which tests you're using. How do you see this moving forward? Because obviously there's a huge pressure to get schools open if we could possibly do it.
Yeah. Well, and there's a huge pressure not to open them until you're sure they're 100% safe. I mean, it's really collision of different ideas. So you have to forgive me. I gave grand rounds this morning on school reopening, so this is all sitting in the front of my brain. So
I know that's why that's why I thought you were probably pretty well prepared for it.
Yeah, finally, forever or something.
Yeah.
So to start with is that children don't get infected as often as adults. That's fact one, right? Why that doesn't happen? There's some physiology to it, that they have fewer ACE2 receptors. They have about half as much as young adults. And so the idea would be if they have fewer ACE receptors, they're going to get less viral replication. But then there's a whole countervailing argument from some studies done in Chicago that said that children, in fact, have higher viral loads than adults. Now, that was done in symptomatic children. It was done on a machine which I have been told is not the right machine to do that kind of study on. And there's a study from Germany that says exactly the opposite on the right kind of machine. So I think that's a sort of, one of these kind of scientific questions that we're going to need a tiebreaker or two to resolve that. But the observation is that children don't get infected very often. And from a variety of household studies done all over the world, they don't infect other people very easily, including other children. Now, there's a whole school of thought that says the reason children don't infect adults is because they're short. And when they sneeze and cough, it goes into the thighs of your glutes or your abdomen. But that seems like a little overly facile argument to me. But the observation is they just don't get infected. Now, having said that, and by the way, for this receptors, the cut point is 10 years of age. There are numerous reports of infections, of outbreaks in middle schools and high schools. And from France, from Australia, from Israel. Those are the ones we look at, and then we can look here look here in our own backyard, not California, but through the South. There are these two high schools in Georgia that opened, and everybody was jammed in the halls, and the kid took the picture and got kicked out of school for a couple of days, and should probably win the Pulitzer Prize for photography or something. Right. But they had 9 cases in the first 3 days, and then had to close. Another one in Cherokee County, which is another Atlanta suburb, similar kinds of things. So I'm not at all surprised about that. The University of North Carolina, not having a particularly good day, had 135, I think that's the right number, 135 cases in the first few days of class, and had to close the university, send everybody home. Here, closer to home, Stanford and Cal have both said, we're just not going to deal with this, right? Everybody go home for the first semester or quarter, depending on which system you're on. So that's kind of where we are with institutions of higher education. They're just not going to be able to, I don't think they're going to be able to pull it off. Now, if you could get frequent testing, and you had a place to isolate people, and you had students who followed the rules, okay, then you might be able to pull it off. And I've been talking to Caltech, of all places, about this, and I think they think, maybe you can get them to maybe. So we'll just have to see. And I think, as far as I'm concerned, well, just to start with, in California, 90% of the population lives in counties that are being monitored by the state. And part of being monitored by the state means you can't reopen schools to in-person education. Now, that creates huge disadvantages to children who are on school lunch programs or breakfast programs. It creates huge disadvantages for special education, children with special education needs, especially physical handicaps. It creates a lot of problems, right? But that's the decision that the governor and the governor's office has made. There is, however, a waiver possibility for elementary schools only, and that's all the business about the ACE receptors and the observations that we just don't see very many. We haven't seen any outbreaks in schools.
So you had mentioned 10 years old as sort of a cut point of some sort. So do you think it's safer to open young elementary grade?
Yeah, I think it's safer.
Yeah.
Now, I'm sure there's somebody out there who's read the MMWR about the Georgia summer camp, sleepover camp, where they managed to get an attack rate of 61% among 6 to 11-year-old kids at this camp. Basically, it was sort of the University of North Carolina story. Everything was done wrong. I mean, I don't know anything about the University of North Carolina, but in this situation, the kids weren't required to wear masks. They slept in cabins of 26 with the windows and doors closed.
Yeah.
So ventilation was a problem. And their big activities were singing and cheering, which create, massive amounts of virus in the air.
At least they didn't have bars.
Yeah, at least they didn't have bars, but they probably, but looking at the timing, it looks to me and to some other people like the counselors gave it to all the kids. And this is not kid-to-kid transmission. This is adult-to-kid transmission. And in fact, in China and all the models about going back to school, in the Chinese models, it's always the teacher that brings the virus into the classroom. So, that's how they're thinking about it.
And so at least very frequent testing of teachers might be be part of the equation. Yeah.
Yeah. The state has it down for every 2 months, which I'm not sure what good that's going to do.
Yeah. So flu. So it's now almost late August. I guess it is officially late August. Tell us about flu. Remind us about the flu season. What about flu vaccine? When do we find out whether this year's version is going to be effective? And then how do we bring this into the COVID era?
Sure. Well, I'm going to answer the second to the last question first. When do we find out that this is effective? About 2 years from now, when we get the studies done. So, don't hold your breath on that one. Right. Interestingly, what's happening in the Southern Hemisphere, which is the harbinger of what's going to happen in the Northern Hemisphere, is that it's been a very light flu season. And it's unclear whether it's the strains or whether it's everybody walking around with masks on.
Yeah.
And the thought is it's really everybody walking around with masks on. And this grand rounds I did today for all the pediatricians in the kind of Stanford orbit, I asked them the question, are you seeing respiratory infections this summer? And they said almost none, right? Because of social distancing and sheltering and mask wearing, it's the transmission rates of all the respiratory viruses are low. So we may get something from that.
Right.
Having said that, however, everybody should get flu shots. We don't want to have given the performance of wearing masks across much of the country, we don't want to have the ICU beds. We don't want to have ICU beds being used up by people with a preventable disease. Now, admittedly, influenza vaccine is not that great. We get maybe 35 to 50% vaccine efficacy, but still that's half the number of people who could be in the ICU beds, and you may actually get less severe strains if you get vaccinated. So it's, that's kind of so the good news is that it seems to be a very mild season in the Southern Hemisphere. The bad news is we have no idea about, because of that, we don't have a lot of data on strains.
Right.
I mean, we do, but it seems to be more behavioral than strain dependent. But get your flu shot anyway, for those of you in TV land.
So going back to the epidemic itself for a bit, it looks as though death rates might be dropping some. Is that just a function of when the virus spreads most rapidly through a community and the delay from that to death? What's your take on that?
I could give you 3 different thoughts on this. The first and the easiest one thing to say is that this is just lagging 3 to 4 weeks, and you just haven't seen it yet. And then there's some evidence for that, but it's still, the rates don't seem that high. The second thing is that the majority of people who are being diagnosed are in between 20 and 49 years old, and as we all know, they're not as likely to develop severe disease and not as likely to die, although they do, as older people. And the third thing is that we've gotten somewhat better, and I will defer to my ICU colleagues to talk to you about how we've gotten better, but through remdesivir and for early infection, dexamethasone, proning for oxygenation. Even if you want to cross off immune plasma therapy as a viable option, which it sounds like the NIH was hanging crepe about that yesterday. It doesn't. I think we have enough tricks that we can reduce mortality. And I know at UCSF, I have heard that that ICU mortality has fallen to about 10%. And early on in New York, it was 80% plus. Italy and stuff was 80%. Now, some of that was picking up the oldest people, who are they going to be the frailest and right, the least likely to mount a quick recovery. But still, I think it's encouraging. I think these are somewhat real phenomena. The other thing to realize, though, this is a great graph that it showed case rates by age groups in Florida, in some number of counties in Florida. And you can see the 20 to 29-year-olds and the 30 to 39-year-olds go up, and despite all the orders and trying to hold it in place. But the 70 to 79-year-olds didn't go like this. They went up in parallel with them. So that means that for whatever reason, there's back and forth between the younger people and older people, and that you're not really getting a free pass for the older people. We're not doing that good a job, at least in Florida, separating them out from the trends among younger people.
So you mentioned it just now.
Sorry.
Hello, dog. Last time we talked, George, it was my cats that were causing trouble, but this idea of post recovery serum collection as a treatment, and I saw that as well, that the FDA decided not to extend the EUA for that.
Yeah.
You want to talk about it? I know you're not really primarily treating, but
yeah, no, I'm not in the midst of all that. I mean, I think they're probably less compelling data than we think about, than there has been. I mean, immune serum therapy has been around since the 1930s.
Right.
And, it was somewhat, I mean, I hate to say anything was a mainstay of Ebola treatment, but it was a mainstay of Ebola treatment. And, it's just a question of what antibody, I mean, there's nothing wrong with it. And, but you can be more elegant than just infusing large amounts of serum and have monoclonal antibody species that are really specifically targeted to what we're trying to control. But the people who get it, we're trying not to. It's not necessarily viral replication we're trying to control. It's cytokine storm and immune system overload and that kind of that sort of the
really sick
pathologic progression.
So here's a question I'm sure that everyone will want to toss around with you. Let's talk about masks. There's been so much, I hate to think how much we've learned, at least I have, about masks. When this started, my son, who's an engineer, gave me these N95 masks with a valve in the front. And
yeah, perfect. Yeah, good thinking, Tex. Yeah,
well, but for construction, I think it probably is good. But
it's great for construction.
We learned that
they're also great for coccidioidomycosis, by the way.
Right. So talk about masks. I mean, we've heard back and forth. I think just in the past week, we've heard that the gauze things make it worse or don't work, or help me.
Yeah. So masks are important. Masks are hugely important. And masks are important for 3 reasons. 3, okay? The first is that they If you're infected, and remember that 65% of people who are infected have no symptoms, and I'm adding the people who are asymptomatic plus the people who are pre-symptomatic together. So 2/3 of the people with this infection walking around and presumably at their most infectious stages have no symptoms. Okay, so that's why we want source control. That's the industrial hygiene term. You know, basically you're going to keep it in. The second thing is it provides some protection for you. Now, it's not perfect protection because you still have your you have a conjunctiva exposed. And, you know, while I pretend that wearing glasses is going to protect me, and I realize they need to have the side things on and have safety glasses and stuff. We've gone to that for patient care here at UCSF, but it provides some substantial amount of protection for you. And the third thing is, and I credit Monica Gandhi with this idea, is that if you get infected, because people are wearing masks, the inoculum is going to be much lower than it would have been otherwise. And so you're much more likely to get an asymptomatic case. And because people with asymptomatic infection develop antibody at the same rate as people with symptomatic infection, she refers to it as variolation, which was an early, smallpox prevention technique that preceded vaccination, where basically we're giving people mild disease with small inocula of the actual organism. So I think that's a third reason. Now, as to what kinds of masks to wear, any kind of mask is okay. Just don't wear it under your nose, and for God's sakes, don't wear it under your chin. And I mean, and I'll say this as a pediatrician, it's a suffocation risk for children under 2. So don't screw around and try and get some 2-year-old to wear this. I have a picture of my granddaughter with a 2-year-old mask on, trying to pull it off, and it looks like she's going to amputate, both her external ears.
Right.
So that would be bad. Be sewing those back on all night long. There was a study done at Duke, and by study, it's sort of like, with all respect to the investigators, it had kind of a high school science fair feel to it, where they were taking, side shots with scattered light and stuff, with a cell phone camera, I might add, for all these different kinds of masks with, ends ranging between 1 and 4. And basically the N95s work great. You can't have the exhaust valve, right? That's absolutely off, right? The N95s work great, but N95s have to be fit tested, so you can't have a beard, you can't have the kind of Miami Vice stubble, all that stuff, right? The surgical masks work fine. The cloth masks that people wear around work fine. What they didn't like as much were bandanas, the sort of bank robber look, and then the gaiters that got pulled up. These were ends of 1 in this study, from which this huge, media storm ensued. And I think that there's, I didn't view that as, it's the typical thing, right? It's, you get, and I'm going to start sounding like I'm beating on engineers like your son. You get a bunch of engineers together who like to talk about fluid dynamics and aerosol particles, and they say, oh, this leaks, therefore this can cause infection. Okay, so then you say, okay, well, what's the infectious dose? How many viral particles are there per droplet? Right. Now, they don't have any idea. Maybe it's just because they can see droplets, they think, oh yeah, well, this is, cause and effect. So this is kind of in that category. And it may well turn out that gaiters and different kinds of materials don't filter as well. But as long as it's 2-ply, I think you get plenty of protection.
Super. So we're running up to the time when we're going to invite the audience to participate more, but I want to, another topic that I really want to talk about a little bit is contact tracing.
Yeah.
And I think we know that it probably can work or can help, but is it really feasible when you get these big explosive epidemics, Florida or?
Yeah.
No.
Yeah. It's totally scalable. You just have to have enough people trained when it needs to be scaled. And I think San Francisco, we've trained a ton of people here, like hundreds, to do this. The usual at San Francisco Department of Public Health, they usually carry 10 people to do contact tracing for all the STDs and tuberculosis. So we've moved from 10 to maybe 250 people trained, something like that, and basically have a workforce, sort of a standing an FTE workforce of about 120 people to find all the cases and do it. And so it is scalable, but you have to have the substrate to start with. You know, you have to have people who are trained and ready to go. I think it's been pretty successful here in San Francisco. We get to 70+% of the contacts within a day of them being named. We've gotten a lot of people into isolation. But, I mean, the whole point of testing, the whole point of contact tracing, the whole point of case investigations, the whole point of all this stuff is to find people who are infectious, take them out of circulation, and put them into isolation. If you can't put them into isolation, there's no point in doing this. It's a waste of money. And the problem is that the people we're dealing with who are most likely to get infected live day to day, live from paycheck to paycheck. And I'm not talking weekly, I'm talking getting paid in cash daily.
Yeah.
On construction sites, on, for farm work, for whatever. They don't necessarily have a lot of cash on hand. They're not living in places that are conducive to isolation because they're sharing rooms.
Yep.
So we have to have we have to be able to have income maintenance. We have to be able to provide social services for them, meaning like food and whatever. They have to be able to go to a place where they can isolate. Somebody has to be checking up on them. And somebody probably has to be providing like food vouchers or something to their families. And then last of all, they need to have some guarantee, if they're truly employed, if they're formally employed, that they'll get their job back when they go back. I mean, understand that a lot of people we're finding through contact tracing that we're trying to isolate are asymptomatic. Okay, if you're in the ICU on a blower, that's an easy one. It's a 25-year-old with a wife and 2 kids who makes $80 a day and has to pay rent in San Francisco and has to put food on the table. That's the sort of and has no symptoms at all. That's the sort of person that's going to be tough to talk into going into isolation unless we remove the disincentive. So, I mean, everybody likes to focus on contact tracing and testing, but the reason we do those is for isolation. And I'm trying to get everybody to talk more about isolation, right, and less about the other stuff.
So we have a bunch of questions. I'm betting we're not going to get to a lot of them, but we'll try. So a couple questions about flu. When's the best time? Do it right away? Do you wait a while? And that was from Chicago. And then another question about the flu is that the question is that it seems to the person that people at risk for severe flu are at least likely to benefit from a flu vaccine. Is that, do you want to talk about flu a little bit?
Well, I mean, so yeah. So the best time to get the flu vaccine is as soon as it becomes available. You want as much protection as possible. As for people who are at greatest risk having the most difficulty with immunization, I think that may be true. I mean, that's why we do double dosing for people over 65. I don't know if you had to wait. I had to wait around UCSF for them to get the higher dose vaccine this last year, and which I thought was ridiculous. I mean, the workforce where we work is not as young as we once were, right, Paul?
I work at the VA, so they have a lot of high dose vaccine around, given the patient population.
Well, I was getting it in the children's hospital. Okay, I'll give you that. I'll give you that. All right. But yeah, I mean, it's when vaccine dosing and vaccine strain selection is an art, much more than a science, and there's a lot of guesswork that goes on because it has a long production lead time, and so we're having to make choices in April about what's going to go into production. And some of that's based on what's going on in the Southern Hemisphere. A lot of it's based on where we were at the end of the flu season in the Northern Hemisphere. But I think my basic advice is to get it as soon as it's available.
Great. So here's a question.
And don't give your children aspirin if they get it.
Yeah, right. Remember that.
Ryze syndrome. Yeah.
Yeah. This is about a patient, and the question is that the patient had symptoms in March, but didn't come in for care at that point. Now comes in feeling well, but had COVID antibody testing, is IgG negative, IgM is positive. What's going on? Does the person have active infection or what?
Yeah, they may have gotten recently. I would have guessed that they gotten recently infected. It's going to have to be repeated. I would suspect that's an error more than anything else. And as far as people, this is my wife every day. When are you going to get me an antibody test? I know I had this in January, in February. I can't smell anything. Blah 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 blah. So go call Kaiser and go get it. Well, no, you have to do it. So you're going to see a lot of people. We had a bad influenza season last year. You're going to see a lot of people who had influenza, had severe influenza, and were sicker than they're used to getting. We're going to say they had COVID. So just the fact that they say they had it doesn't mean they had it, right? It's not a particularly specific diagnostic tool. And then we'll see the antibody. Now, one of the things is how fast does antibody wane, right? And antibody for all diseases wanes quickly. After you were talking about measles, it goes up, it goes down, right? That's what it's supposed to do. But whether you can, how long out you can measure it is a very much of an open question right now. For the alpha coronaviruses, it's sort of on the order of 4 months. So you could potentially see somebody. Here's another explanation for this. You could potentially see somebody who had waning immunity, who had true disease, developed antibody wanes. They come into contact with someone with the disease in the community, and they have an amnestic response that's characterized initially by IgM and then later by IgG. Remember, one of the things about the immunology of this is that people are getting continuously boosted because of the people they come into contact with who are infected.
So
that was an AC diagnosis. I like that one.
Yeah. So question about, I'm going to broaden this question, but says, why did we only get recommendations from the CDC regarding face shields for PPE recently and not earlier? And maybe just without getting too political, talk about the CDC and what's been happening.
Yeah.
With regard, talk about face shields, yeah, because that's
sure. With regard to face shields, we've had them since very early on in the epidemic, used mostly for hospital infection control. That's when you do NP swabs, you're supposed to have a face shield, for instance. So, I think this is the teachers that have pushed this as an issue. It doesn't hurt to have face shields. It's probably better to have safety glasses than face shields. But
you still need a mask. You still need a mask.
Oh yeah, absolutely. Oh yeah, absolutely. It's not a substitution.
Yeah.
So CDC, and I've worked for CDC for years and with CDC for years, and and I know the zip code and everything right off the top of my head, and the main information number off the top of my head. But CDC likes to control things, right? And remember that in the United States, public health is a duty of the states, not of the federal government. The federal government's remit for public health is to control disease at the borders. And the actual law used to say, when Paul and I got into this for HIV in the 80s, the law at that point in time said loathsome and contagious diseases as the ones they were trying to keep out. Right? So those things like tonsurans and other big time pathogens like that. So CDC likes to control things, right? And I think they had a basic misreading on how many cases there would be. And they thought there would be tens of cases in the United States, maybe 100. And so they were going to
SARS-1 kind of version.
SARS-1 kind of thing. And they're going to control the diagnostic agents so they would know where every single case was, and they were going to run all the tests so they could figure everything out. That lasted about a week before that was shown to be an absurd premise. But meanwhile, they hadn't produced enough test kits, FDA threatened to shut down their laboratories, in a real spate of internecine warfare. And they've never really recovered from it. Plus the administration doesn't help them out. The White House task force sort of continuously undermines them, I think, which it's a lot about old time payback for a variety of things. And they just haven't recovered. And even if you go to the website today, I can tell you they don't have the age, you can't figure out the age distribution of the patients with reported COVID-19. They put that out in MMWR. They suppress they don't suppress it. They just don't present it. And it's really been left up to the states to do this, which I think is okay. Although sometimes you're going to have federal assistance for stuff. So it hasn't been the finest hour, even though that's what the centers were built for in the 1940s.
George, a couple questions about what you'd mentioned, that you'd mentioned Monica Gandhi, that it might be the inoculum size that would lead to more likelihood of more symptomatic disease. Is that pretty well established? Or have there been studies, and talk about that?
It's supposition. I mean, it's well established for other diseases, but it's supposition at this point in time. But I think it's probably not inaccurate. I mean, the gross observation is that disease is getting, did I say this? That disease is getting less severe. And we're getting fewer people in the hospitals and fewer ICUs and fewer deaths. And that would be consistent with lower inocula leading to less severe disease. In the old days, these were done with prisoner experiments, right? So if these guys want to get their way, who want to be challenged for the vaccine, we'll be able to answer the question, because we can
adjust the dose,
adjust the dose in the placebo arm, right? And we'll get an answer. But no one's proposing that, even though I guess Dr. Fauci said it was Plan D, as in dog.
Got it. A question about vaccine development, given that the intense pressure on one government versus another, one company versus another, everyone's going at warp speed. Is there a risk here, and what are your concerns about safety of vaccines?
Well, I mean, it has to be, safety of vaccines is always something that has to be balanced with the need. And this is an expanding epidemic. There's tremendous need. And I think when Francis Collins talks about this, Dr. Collins, he talks about not cutting biological corners, but just cutting it, sort of administrative, company profit corners. If you believe that, which I think is probably believable, then we should have relatively safe products available. Now, I'm worried though that we'll have a DSMB that'll stop the trial early, because you're going to get a big difference, right? And we're going to end up with 5,000 person years of observation, and then we're going to start vaccinating 330 million people, and we're going to start finding side effects that occur 1 in 50,000, 1 in 100,000. Those sorts of things, and they're going to be very difficult to figure out. There are 2 vaccines in routine use now, not in the United States. One is a Canadian Chinese vaccine, CanSino, that's being given to the People's Liberation Army. So who knows whether those data will be published about side effects. And the other is this Russian vaccine. I was asked the other day, if Putin were here and if President Putin were here and offered me a dose, I'd say, well, you get it first, pal.
He says his daughter got it already, but I'm not sure.
But not him, right?
Sure,
not him.
Here's a kind of an interesting question. For routine COVID care, how much PPE is really needed? The questioner says that she'd rather have an N95 than a gown. Do we know we don't worry so much about surfaces anymore? Is all of the PPE really needed?
Well, we don't worry about services as much anymore, not because the virus has changed, but because our understanding of it has changed in the observed transmission, and we can see kind of transmission patterns. I would think, yeah, I mean, I think if somebody's acutely ill and they're at a highly infectious stage, you need as much, and you're going to be instrumenting their lungs below the level of the larynx. You need everything you can get. For if you have somebody who's staying in the basement, like Chris Cuomo, where they threw the food down the stairs every night for dinner. You probably don't have to go to extraordinary lengths, but I agree with you. I'd much rather have N95 and safety goggles or safety glasses than a gown if those were the choices. Hopefully we won't have to make those choices, but there certainly is a theoretical possibility of fungite transmission. It just hasn't been observed very frequently.
Yeah. A question about air filtration systems, ventilation. Comment on that. I've also heard questions about UV light.
UV light is great, right?
Well, not in your body, but
well, I mean, saying that's not a good idea. I mean, people say, well, can children use playgrounds? And I think, metal surfaces that are being doused in UV light in the middle of the summertime, it's probably pretty safe.
Yeah.
So air conditioners, ASHRAE, this may not an organization that may not trip off your tongue, but the American Society of Heating, Refrigeration, and Air Conditioning Engineers has just issued new standards about air exchanges and about ventilation and about filters for air conditioners in places where there are a lot of people. I think that's what we're trying to deal with here are aerosols, which are relatively less important mode of transmission, but they do occur. And I think that those standards are the standards to follow. Basically, you want to amp up the air exchanges and have 6 air exchanges in a room per hour at least. And you want to and if you have some clunky old air conditioner you may not want that. But if you have a fancy air conditioning system, you want to have the highest grade filter. The ASHRAE takes, courtesy of Legionnaire's disease, ASHRAE takes these ventilation standards very, very seriously, and the risk of transmission very seriously.
Great. Again, I know, George, it's probably not fair because you don't do a lot of direct patient care of these patients, but we all hear the stories. What about the late effects? People that seem to have very prolonged illnesses.
Yeah. There's somebody that we know who was in the New York Times with an article about how she had late effects. I mean, it's if we had any disease and we started to follow it as closely as this, I suspect we'd be seeing these kinds of effects sort of over the longer run. We know that for the 1918 influenza, there's a whole school of thought that that may be the cause of the epidemic of Parkinson's disease that started in the 1950s as real late disease. But clearly people don't snap back from this. And what it made me think of, Paul, was people who've had Guillain-Barré syndrome, speaking of vaccines. And you say, oh yeah, you'll be fine. This isn't polio. You'll come right back. And, a year later, they can still barely walk and they can't really read very well. And, it's like, it takes a long time to come back from some diseases. And I think this might be one of them, at least for some subset of people.
So we're getting close to the time. We still have a number of questions, but the questioner is about riding a bus. Is that safe? And if you, should you wear a mask or gown? Yes, of course you wear a mask.
Okay, you should always wear a mask. Let's go there first. I think, as long as you can maintain some social distance, I think it's fine. You don't want to be on, like jammed into the Tokyo subway cars.
Right.
Probably not a good idea. We actually worry a lot about buses, but in terms of taking agricultural workers out into the fields. And we think that might be one of the big sources of transmission among agricultural workers that we're now seeing up and down the Central Valley. So I think if you're talking about city buses, that's fine. Just wear a mask and make sure that you can, make sure everybody else is afraid to get on, and so you don't have to sit next to anybody. Right. And if people are on the bus not wearing masks, call Uber.
Yeah. Well,
Or Lyft, or Lyft, or
or
Lyft,
Lyft.
or any rideshare
It
application
is,
you
it
want.
is the top of the hour, George. It's been a great discussion. I think, judging from the comments from the people, we had a lot of questions still, but this has been fantastic. The field changes so damn fast. It's just amazing. But I'll be nice to you and we'll invite you back. Maybe
Thanks,
I'll
Paul.
give you a beer. Thanks, everybody. And just a reminder that you can find out more about activities like this, all the different things that the International Antivirus Society USA produces, the website, you see the URL there. If you have comments about the dialogue series, email us. We'd love to hear comments, and it'll be available as a podcast after the live broadcast is over, but we welcome your input. And George, thanks so much for joining us today. Really do appreciate it.
Always a pleasure. Take care.
Yep. Bye-bye.
Bye-bye.